route that some.
Well, I think you're thinking that it ought to be only catastrophic, and we can think about that. But catastrophe, I think a way to think about it is that if you need significant healthcare, it is considerably beyond any individual's means, and you need to pool the risk. And you're raising the question as to whether individuals should bear some responsibility for paying. We could think about what we call deductibles, the amount you pay before the insurance kicks in, or cost sharing, which is the amount you pay toward an individual service. But if we think broadly, I think, Jeffrey, you're not disagreeing that some insurance concept matters, that it's appropriate. But what happens, what I asked is, what happens if you don't have it? I think I asked that. I don't even remember what my question was. I'm seeing Brent, did you want to contribute to this? I see you're a pathologist. Where'd Brent go?
Sure, I'm here. Yeah, I mean, I'm a physician, and I work in an academic medical center and look at every case that comes to me, and I don't even know if people have insurance or not.
So, okay, and that's, you're talking about a hospital employed physician, and you're not the entry point, right? So I think that that's an important piece. So for some, the industry is not uniform, and but I'm going to come to it say more in a second. Ella, I'm taking over your job because
that's fine. I was going to. Chris and Sophia have hands up, but you do.
Good.
You.
Good. Hi, Chris.
Hi. And hi, happy people, and happy to see you again. I know that certain hospitals, if they receive Medicare funds, then they have to take a patient in on an emergency basis and identify and stabilize the patient. That is something that's required, and I learned that in Judy's class that I'm taking this semester. But I do know that we absolutely need to have health insurance or health services that are available to all, because we need to make sure that everyone is going to get access, equal access to quality health care wherever they live and whatever they make for income.
Okay.
And
I'm going to cut you off, Chris, because I appreciate your statement and your characterization, accurate and precise, about people's getting being entitled to guaranteed emergency care. And I want to say more about it, but Ella also called on Sophia. Sophia, did you want to say something in the same vein?
I was going to say, even though that, like, I used to work for a nonprofit, and we enrolled people in health insurance, and we advocate staff. And Vanderbilt is one of the major hospitals in Nashville, and if you do not have health insurance, they will not take you. And and I think that's so. Let's connect the two pieces of information. That Chris was right to say that that hospitals that have emergency rooms and that take Medicare, federal health insurance for older people and some people with disabilities, are required to stabilize people in emergencies. But that stabilize doesn't mean address an underlying condition that is leading someone to present. So it is a limited amount of care, and it is, even though some hospitals do take care of people, in general, when you gave us an example, Sophia, of a hospital that did not, in general, we know that people, when we compare, which is the way you would do this, is to do research to see whether the differences in access to care for people and in outcomes for people who have health insurance and people who don't. And we find that people without health insurance get care later, get less care, and in facing similar conditions, doing that kind of comparison, are more likely to die than people who have health insurance. So some care, yes, but not in any means the same care with the same timing. So insurance matters to your health. It also matters to your access to health care. It also matters to your pocketbook. And somebody might want to say something about that, but I see a couple of hands up. Ella, I'll turn to you.
Yeah, Dr. Berman, you're next.
Yeah, and just to give a real life example, a friend of mine who accidentally cut off his finger while repairing a motorcycle, and for some bizarre reason called me. He's uninsured. I said, put the finger in a baggie with ice and go to the emergency room immediately. He did. Finger could have been reattached, but he didn't have insurance, so they wouldn't reattach it. They just bandaged it, and he's missing a finger now because that's not a life-threatening injury, right? They
But
stabilized
I thought
him.
you were going to say they did it. It's amazing how one can continue to be shocked. It really, thank you. Yeah.
And John Anderson.
You're muted. Can't hear you.
Oh, you're muted. Yep. If you hit the space bar, that may work.
But I got it.
Yep, you
Oh.
do.
I'm a nephrologist from Hopkins, and I spent many years dealing with the end-stage renal disease program, which is unique in that it's the only disease-specific insurance coverage, regardless of your income and regardless of your means. It has a lot to say, I think, about insurance coverage and health coverage in the United States. Any thoughts on that?
I think, John, it's a good point. You are correct that it is very rare to have a disease specific. A couple of diseases have been added to end stage renal.
ALS.
And right, and when the way in which this coverage was added to Medicare was I believe they dialyzed a patient on the floor of the house, so it may not even have been.
That's true.
Right. So, and it was so dramatic because there was technology. It was very visible that new technology had developed. This is in the 70s that could keep an individual alive and functioning, but that was totally unaffordable. And it was a federal program. Doing it disease at a time, I think is a little unfortunate. I don't know whether you're lucky or unlucky when you get one of those diseases. I'm kind of on the unlucky lean in that direction. But I think, John, what you're describing, and I think there are plenty of issues in that program, but that we're not addressing today. But that is a public insurance guarantee without qualification based on age. Health, it is tied to your need for the service. And if we thought about a government health insurance program, and I saw we had a Canadian participating, if the government is providing everybody health insurance, and they can do it in lots of different ways, then everybody it's not a question of whether you have it or whether you don't. There may be other issues, but that's not the issue. In our country, it is an issue. So, and we didn't get to the financial. I'll offer it up. If you get care, I bet even for what they did for that friend of yours, Adrian, whose finger they did not reattach, I'm confident they charged the person for whatever they did do, and probably significantly, kind of adding insult to injury, to be precise actually about it, and so if you do get care, I think you would all recognize that that's a substantial cost, and they do come after you for that money. So we know about healthcare and bankruptcies and those kinds of issues. So I'm going to posit assert that we agree that health insurance does matter to individuals' ability to get care. We're good with that? All right. Now, how do most people in this country get health insurance? Different from other countries.
Is it employment, I'm guessing?
Absolutely, Sarah. It is through employment. Is there any public policy involved in that?
Sure, quite a bit.
Well, let me hear what it is.
There are laws.
Not so much. Not so much. So hold that thought.
There are rules about. Oh, I'm going to shut up before I embarrass myself.
you're not a bit embarrassing yourself, Brian. But if there's something, it is actually, there are not a lot of rules, is something for you to know, but there is an underlying support. Does somebody have a concept of what that is?
Can I
You
answer?
may.
Is
You-
it ERISA?
You can call on yourself, Ella.
Okay, great.
Yeah, and it is, no, ERISA actually exempted it from regulation. So
There
that's,
we go. That's the
Is it-
problem. Yes.
it's federal benefits law, but something that a federal policy that actually, I'm going to talk about it in a minute, that built our employer-sponsored system and it didn't just emerge out of the goodness of their hearts or some other motivation.
Maybe if I might come in there.
Yes.
Yeah, I'm Taona. I'm coming from Zimbabwe. I just wanted to distinguish maybe the types of health insurance that we have in Zimbabwe. We have social health insurance, and we also have private health insurance. So I just wanted to distinguish that in terms of coverage, as maybe compared to United States of America, I think maybe coverage in terms of health insurance is quite limited from a Zimbabwean perspective. It's mostly available to working employees, as some of my compatriots have alluded to. But I think in terms of coverage, it's very poor.
I appreciate that, and I think bringing in that perspective, what you raise for me, it's often other countries look to each other for what to do on various policies, but they tend to go their own route based on their own history, and it's our history I'm going to describe to you. But for developing countries, there may be a tendency to look to the US and see if it's the way to do it, and the answer is no. Ours is because for the reasons that we're going to come to in a moment. So a place like Zimbabwe would I would posit that our employer coverage is much more generous and more widespread than is true in Zimbabwe, and that you have a much larger population of people who don't have that connection with employers who cover. And the challenge that a developing country faces is that it's kind of the opposite of the story I'm going to tell you in a moment, when most people get employer coverage and we have a minority left out. If you have the majority left out and all the resources are going to the minority with, you have a tremendous problem in getting adequate coverage to everybody. We have that problem even with only a minority left out. But I would argue, I appreciate your bringing it up because there are different challenges. Let me I've got a couple of hands up, and then I want to move on to tell you how we got here. Go ahead, Ella, I talked over you. Go
You're
ahead.
from John, Brian, and then Annette. Oh, haven't heard from Annette, so.
And I haven't told you, wait, before I take the question, and did you want to still answer me the policy, or you want me to tell you? The hands up are going to tell me the policy or not? They're going to tell me the policy?
Yes, they're going to try.
Okay, all right, go ahead, John. Oh, John, you're muted again.
I know, it keeps cycling back. Can you hear me now?
Yep.
Okay. My understanding is that employer-based health insurance came up in the Second World War during price controls as a way of providing increased benefits to employees where they couldn't raise wages. And I understand that the biggest government subsidy of that has to do with the tax policy for the corporations providing the healthcare insurance.
It's definitely tax policy. The World War II policy was also important in giving it a boost. I'm going to define the tax policy in a second because I want to modify what you said just a bit, because the primary motivator here is to the individual, and I'll clarify that for you. Brian, what was Brian next? Ella, is that right? Okay, go ahead, Brian.
Yeah, I was going to bring up the IRS rule making premiums to health insurance exempt from the certain taxes that wages. So it encourages, laws are there that encourage employers to provide health insurance. They don't require it, but they
Precisely correct. And I'll say just more in a second. And Annette?
Hello.
Yeah.
Yes, hello. I'm participating from Sweden, and here it's inscribed in the healthcare law that healthcare is should be based on needs, not on anything else. So it's equal access to care, and it's the needs.
And thank
People
you. And
shouldn't be treated differently according to anything but their healthcare needs.
so Sweden, Scandinavia, in social insurance in general, beyond healthcare, Scandinavia is the strongest, or has the strongest systems of collectively providing for everybody's healthcare. So it's kind of at the opposite end from what Tona brought us, and I thank you for that, and very different from our circumstance. And but going back, so our primary mechanism, in contrast to what Annette just described, is that we get our coverage through our employers. That's the primary means of people getting coverage. It is, as both of you said, Brian and John, it is supported through a tax break. And that tax break means, so the way to understand the tax break is that when our employers pay premiums on our behalf, that amount is not treated as income to us. So it's essentially a pre-tax benefit. If instead the employer gave us the money and sent us shopping, and say we had a 15% tax, we'd only have 85% of that with which to buy health insurance. So employer-sponsored health insurance, John was right to think about the World War II period. It emerged in, now I'm going to go on to give you the history of our system, because people sometimes, well, no, I don't want to do that. I want to stop and get the rest of the system. But it didn't emerge by accident, and that's what we'll get to. But think of it as a benefit not only to the employer, but the employer, if the employer pays wages, they also don't get taxed on that. A little bit of payroll tax, but there's not an income tax. So the real issue is that we benefited from getting coverage from our employers. It got a boost in the World War II period when wages were regulated, but benefits were not. But that tax benefit is the fundamental driver of our employer-sponsored system. Now, tell me about how else, how do other people get health insurance?
Sophia?
Ella, you calling on something?
Sophia?
The marketplace.
Yes. So let me hold the marketplace, and you're absolutely right. That is a relatively newcomer to the system, but very important. But I want to hold it for a minute because I want to talk about. The marketplace is very small. It has gotten a lot of attention because it's important and new, but it is a relatively, if I remember correctly, it's about 6 or 7% of the population. It's not real big. Okay, so we're going to come back to it because it matters, and we're going to talk probably more next time about the Affordable Care Act. But let me hear how other people get health insurance. I saw in the chat who said Medicare and Medicaid. That's a very quiet me. Who's the me?
I'm sorry, the physician.
Ah. Okay, Brent. So who gets Medicare?
People who are not wealthy enough and are deemed needy of it.
Not quite.
Did you say Medicare or Medicaid?
I said Medicare.
Medicare, yeah. No, that's age-based.
It's both. So Medicare is for Social Security beneficiaries, people ages now 60. Well, it's old Social Security eligibility because it's still age 65, age 65 plus, but you have to have earned health insurance, earned Social Security, and you get Medicare. And people who become eligible for Social Security as permanently disabled, but that's not all people with disabilities, are also eligible for Medicare. And Medicare is a fully federal government insurance program, probably different in significant ways from the Swedish system, but it is a government health insurance system, actually in quite significant ways, because it's becoming, that's a longer story. It's allowing people to get their benefits through private insurance, but historically it was established, and more than half still is, a government-run insurance program. Now, Brian went a little ahead on Medicaid, and I saw Sarah put up CHIP, the Children's Health Insurance Program, which is a little program added on top of Medicaid. Who gets Medicaid? Brian had it a minute ago. That is income-based. And it's not federal program, it is federal state. So you have to be poor, since the Affordable Care Act, poor and with incomes below 138% of poverty in states that have accepted the federal money to provide it. So we still have 11 states who have not accepted that. Historically, Medicaid was designed to only cover what were considered in this country's history the deserving poor. Those would be children in single parent families, younger people with disabilities who didn't qualify for Social Security, and older people to cover the amounts they were expected to pay under Medicare primarily. It expanded over time to cover some children in two-parent families, but until the Affordable Care Act, that income eligibility level was very low. So Medicaid is covering, and we'll get to who's left out in a moment, the significant portion of low income people. That's Medicaid. And we went to the marketplace. Before we get to the marketplace, well, who buys coverage in the marketplace?
I can answer if no, I can attempt an answer.
Go
People
right
who either don't have insurance through their employer, can't afford their insurance through their employer, or low-income working adults who don't qualify for Medicaid.
That's okay. Nicely said. And that is an initiative that came in implemented. It was enacted in 2010, implemented in 2014. The Affordable Care Act, or Obamacare. It aimed to fix a problem that we had until then, which is, as Ella is saying, she's talking about people who don't get coverage through their jobs. How do you get it if you don't get coverage through their jobs? And the challenge that insurance raised, raised for insurers and individuals, that insurers were afraid that if you buy it on your own, you're only getting it if you know you need health care. And that can insurance work if you only buy it when you're sick? See a lot of head shaking. Somebody want to put words on why not?
No. You need to, well, like being insured like year round is always good, because God forbid worst case scenario happens, like something happens and you're not expecting it to. And also like paying into a plan like helps like with coverage. Again, like God forbid something happens. So like say you have a deductible and you've already met the deductible for the year and you get really sick, then you don't already have to meet your deductible. It's already been met.
Okay, good job, Sophia. You're focusing on why it matters to the individual. I'm thinking about why it matters to actually paying for the healthcare. So think about the way in what insurance, whether it's public or private, it's collecting resources from a lot of folks.
And Matt and Brian have their hands up. If they want.
Okay, does somebody want to pick up where I'm going off? Matt?
I was going to say that for people that have health insurance, that is not just when catastrophe strikes. It puts a much lower burden on the economy as well.
Because you think it keeps them healthy and working is what you're thinking. Mm-hmm.
Yeah, they're using it.
Yeah, but again, I want to think about the mechanism. You're absolutely right. That's a reason, a value to insurance. But let's think about how insurance works, how it gets the it makes it so that the burden or the risk doesn't fall just on the sick person. Brian, did you want to take that on?
Sorry, my spacebar wasn't working. The young and the healthies subsidize the sick and the old.
Well, it's that may be generally true, but let's just go with sick and not sick. And I see that John Anderson is talking about risk pools. What we talk about it as a pooling of risk. What insurance does is bring together revenue from lots of people, could be through the tax system if it's a public system, but in private insurance, it's all our individual premiums. We pay them when we're healthy. And then the money, most of us are healthy most of the time. It's a minority of the population who get really sick, who absorb the bulk of the resources. And so they get them from all of us and they contribute when they're healthy so that the resources come together So we have them for the minority who are very sick. That's how insurance works. Everybody with me on that? Okay, so if you only sick people are buying, what would happen?
Money gets all used up.
Well, it's everybody's expensive, and it becomes back to your premiums got to go up to cover that. So it's coming back to everybody essentially paying their own costs. So you need some mechanism to pool that risk. And does that make sense to everybody? Did everybody follow? We create a pool of resources to redistribute based on need. That is what the insurance is doing. And it was in the Affordable Care Act that creation of the marketplaces created a mechanism that people who didn't get coverage in other ways through their employer or through Medicaid were able to buy that insurance affordably, because prior to that, private insurers wouldn't take you if you were sick. They wouldn't take you if you're sick. You might get, I think of it kind of like auto insurance. You get maybe one good accident, and then you pay a fortune, right? So, but it might not even be like that in health insurance. And with non-group insurance, we called it non-group to distinguish it from the employer. You got a limited benefit, and probably not very good because they wanted to keep it cheap so people would buy it, but it was lousy coverage. And didn't cover expensive stuff, had a low out-of-pocket ceiling. And if you got sick, they threw you out. And they checked before, and they even checked after to make sure that you hadn't lied to them about being sick or to try to find some excuse for not covering you. So that's how people get coverage. Now, I want to ask you the problem here, because I want to get you to the failure of the system. The failure of the system, or the flaws in the system, what's broken, is that not everybody finds a place here, right? So who's left out of this system? And there's a hint, now people can participate in that marketplace, but many don't, in part because we'll talk more about the subsidies are not good enough and the benefits are not good enough, is the primary reason. But many more do now than before the Affordable Care Act. But who was systematically left out of this system, do you think? We talked to, I'm going to have an answer without my... Go ahead, Brenna.
This is just a guess, but I know like in the past, it was a lot of like part-time workers, like people who weren't eligible for health insurance through their employer, but also didn't meet the requirements for either Medicare or Medicaid. You
nailed it. I'm just going to broaden it. It's not just part-time workers. Employer-sponsored coverage never covered everybody. It was always more likely for the better paid. If you were in a big manufacturing company or a big industry of any kind, you were more likely to get it. But that if you were in a low-paid job or even in big firms, there could be barriers to your getting it, like waiting periods. You had to work for a certain amount of time. If you had a part-time job, you might not be eligible for it. So it was never everybody were covered. At the high, we were in the 60+%. I think it's of the under 65 population had coverage. So maybe of the general, overall, but I'd have to double check. But there were always people left out, and they were the low wage workers. Think about it this way: they were low wage workers or people in the families of low wage workers or of non-workers, but predominantly workers who did not get coverage to their jobs. Okay, and had too much income to qualify for Medicaid. And now they have an opportunity to participate in something, but they are not all participating. You're adding interesting things in the chat. Adam, did you want to contribute here?
Yeah, I was just going to say there's overlap here with some of what you're saying, but undocumented people who are homeless, people who are part of an underground economy.
Absolutely, absolutely. I think, and they are in trouble. They continue to be left out of the system. I think the bigger picture is you want to think about this is if your core was employer-sponsored insurance, you want to think about who's left out of that and how well did we patch that hole. Okay, and we have never patched it, although we do better now than we have historically done by those low-wage workers who were left out. They're not getting coverage for their jobs, and they weren't eligible for Medicaid because they fell into that. They were adult. They were not, I can't remember if I said this, Medicaid was only for, the deserving poor and adults who were not connected to children or not disabled were expected to go get jobs that had coverage, and the jobs didn't offer them coverage. So they were systematically excluded. And that challenge, that was the result of choices. That's what I want to, my take home message today is that this is not an accident. These are people, as I indicated earlier, lament the holes in the American healthcare system as if they just happened. They didn't just happen. They happened because of political decisions. And in the early period of in the early part of the 20th century, other countries, industrializing countries, were developing government-run healthcare systems. And we barely had a federal government. And it was not a primary concern to the state. Healthcare at the beginning of the century couldn't do much for you. You went to hospitals to die. But as healthcare began to do more, people needed health insurance, and there was some activity. Teddy Roosevelt ran on a campaign to get everybody national health insurance in 1912, and he didn't win. And there was some effort in the teens to get coverage, but it was attacked. Those policies, those strategies were attacked as German. We were at war with the Germans, or when after the Russian Revolution, they were communist. And there ought to begin to, that's a refrain that carried on from that period. Anytime that we talk about government health insurance, even when it's not very government driven, as in the Affordable Care Act or government run, it's challenged as if not so much communist today, but definitely socialist. You've all heard that refrain, right? Now, you don't need a lot of creativity. This playbook has been going on this song has been sung for 100 years. So we didn't build it. Instead, we built employer-sponsored insurance as it came out of in the Depression. We did not get government health insurance in the New Deal. Roosevelt was Social Security, pensions, retirement was a priority for him, and the medical association was very much opposed. Big business was opposed. So he was going to come back, he said, but his politics did not allow that, or he did not come back. And so in the absence of federal government insurance for government health insurance, at the same time as the New Deal, even the docs on the ground, if not the leadership of the American Medical Association, needed to get paid. People had no money. And so they formed the first health insurance was formed by hospitals working with business leaders in communities to create Blue Cross, to collect money. And they found that if they could collect it through the employer, then they could get a large group of people, not all sick, in fact, mostly healthy. So they weren't at risk of what we call adverse selection, only sick people signing up. And that began group health insurance. And it was supported, as we said earlier, by the policies in World War II, but it was from the beginning that tax benefit, first informally and then codified in 1950, made it in the individual's interest to get health insurance through employers, and in the company's interest to provide it in order to attract workers. So that became the core of our system. And although there were efforts after that to get rid of it, to have a public health insurance, all the way it happened in the 40s, President Harry Truman tried it. I'm going to skip over what happened in the 60s, but Ted Kennedy was trying it, and even Richard Nixon, well, no, that was employment-based. Teddy Kennedy was trying it in the 70s. But once we built that employer-sponsored system, it became entrenched. We call this this policy path. It became path dependent because so many people and interests became invested in this system that we argue that it kind of crowded out the capacity to get rid of it and have government health insurance. So what happened instead after the 40s, moving into the 50s and 60s, the advocates of national health insurance shifted to trying to get coverage for people who were left out of the employer-sponsored insurance. The obvious group was old people, followed by, I was young then, but I'm now a poster child, okay? Although I'm not a poster child because I lift, okay? Older people were not getting coverage, and I work. But older people were not getting coverage through their jobs. So, and they were getting Social Security. Social Security was popular. Let's cover old people. In a few years, people with disabilities who qualified for Social Security were added. So that was Medicare and that government health insurance. Their goal was to start there and cover everybody, but they ran into this core of employer-sponsored insurance. At the same time we got Medicare, we enacted Medicaid for the deserving poor people. So all those adults not connected to children and not getting coverage through their jobs were left out until we did the Affordable Care Act. And then finally, we got the Affordable Care Act, which I'm going to talk to you next week about. Well, can I do it? I can do it now. I can do it pretty fast. I can just, yeah, I can do it. I want to do it because then it'll be a good jumping off point for next week. Okay. So the challenge that this left, meanwhile, actually, let me tell you what was happening in patterns. I told you employer-sponsored insurance never got everybody. We got Medicare and Medicaid to fill in some of the holes in the 60s. But the other consequence of not getting everybody covered through a government system is that we didn't do anything to have government have an influence on healthcare costs. Other countries that built national systems also have budgets that determine how much they're spending on healthcare. Now, as the cost of healthcare rises, they may spend more than they want, but they have mechanisms for managing what they spend, what providers get paid, that we do not have. Our payments are that the government has authority over what government pays, and they regulate payments, but not what gets paid in the private system. And as a result, our healthcare costs have risen dramatically faster than spending in other countries. So we now spend twice, and have for a long time, spent twice as much per person than the average of comparable countries. We pay a lot more for it. And as costs went up, more and more people were not getting coverage through their jobs. That coverage did not grow with the growth in the population as it was, and was affected by the increasing costs of care, both in the scope of its coverage and in the adequacy of coverage. So that's what's been broken, both coverage and costs in our system. And the challenge in fixing it is that if you have, which was the case when we started the battle for the Affordable Care Act, if you have 85% of the population covered through some mechanism and only 15% out, and as we've just left without, and only if that 15% is not politically powerful, which they are not, they are people disproportionately low-income people not getting coverage through their jobs. They don't band together. They don't have time for this. They don't have uninsured on their forehead. They don't necessarily think about it, but they are a minority that we can identify who were left out of the system. The challenge politically is, how do you bring them in without enabling those who oppose it to scare the bejesus out of those of us who have health insurance, that we're going to be worse off as a result? And I'm going to tell you the answer of how the Affordable Care Act did that. And then we're going to take it apart and think about where to go from here in next week's session. The Affordable Care Act influenced by lessons from the failure of what we called the Health Security Act, only it was never an act in the Clinton administration. They're designed a policy, adopted a strategy to focus on the two, what they perceived as two fundamental coverage problems. We've addressed both of them. One was the failure of Medicaid to cover everybody poor, regardless of their family status. So that deserving, undeserving poor thing. So they attempted, the Supreme Court did not allow it, but they attempted to make Medicaid at federal expense, overwhelmingly federally paid for, cover that group. 11 states don't do it, as I said before, and they are where the largest share of uninsured people and largely people of color, disproportionately people of color, are located in the South. But the attempt was to fill that, to close that hole. And the other thing they did, which we already did talk about, is they fixed that market, that non-group market, so that if you didn't get coverage from your employer, you could go someplace to shop. And as I said, there are limits to that. Not everybody's participating. And it is largely low-income people who aren't getting coverage through their jobs, who are still uninsured. But we made a hell of a dent in that population by creating a place with rules where insurers have to take you, whether whatever your health status. And we said we can't do that if there aren't other rules. A rule that initially existed was that everybody had to buy health insurance, and it was so that you wouldn't wait till you were sick. But that has Congress reduced that penalty to zero, so that's really not terribly operative. But the other thing you've got going for making these markets work is you provide subsidies. And we're getting very good participation in the marketplaces for people who receive the subsidies related to income. And we have enhanced its protections in COVID-related legislation and in the recent Inflation Reduction Act to expand the subsidy to make it possible for people to afford insurance. As I said, not everybody views it as affordable, but that's the way it's designed. So these were very precise, specifically targeted policies. I would say very gentle. I have a former friend. We stopped being friends on revealing my politics. I wonder if she ever listens to anything that I'm on. When she told me, I grew up in Florida, when she told me the Tea Party was the greatest thing that ever happened to her, joining the Tea Party politically, I knew it was doomed. And when she told me that the Obamacare was socialized medicine, I told her, I said, I'm a fan of socialized medicine. Trust me, this is not it. Didn't do any good. So we parted company. But it is, and I love that. I like telling that story and you're smiling, so I forgot where I was going. So we made a dent, but it is a very cramped policy, that policy. And what I wanted to, it still leaves lots of holes, and it is still with lots of pieces. So it's not smooth as a system to either get everybody coverage or to control costs. And so again, I want to talk about next week about what's been successful, what's not successful. And I want you to think about broadly where you think we ought to go next, and how we would get there. And I'll lay it out for you. We've heard a lot more in recent years than we did for decades about national health insurance, that some call it Medicare for all. Bernie Sanders put it on the map. So that we've heard about that. And I imagine you'll have views about that. Or the alternative, we just keep fixing what we got. And that's what I'm going to lay that out for you next week, and be interested in your views and plans for getting us further along in terms of securing affordable health insurance coverage for everybody. And I think that's a good place to stop. Ella, does that seem right to you?
That was